Good morning, everyone. Hope you're all doing well. We're approaching the end of the semester, and this is your GI lecture for Module 5. And just like my other lectures I mentioned before, we need to make sure we cover everything that's going to be on the test. So pay attention and have fun. And so before we delve into the GI disorders, let's just do a quick introduction of the GI system. So as you know, the intestinal system is composed of small and large intestines, and enzymes are secreted throughout the small intestines to aid in the breakdown of food into absorbable nutrients. So the main function of the intestinal system is basically digestion, absorption, and elimination of waste products. The small intestine is responsible for the absorption of nutrients, and the large intestine is responsible for absorption of water. There are 3 sections to the small intestine. That's the duodenum, jejunum, and ileum. And so most of the disorders we'll be talking about will be making reference to the to these systems. And the large intestine is basically the cecum, the colon, which includes the ascending colon, transverse colon, and descending colon, and sigmoid colon. Okay, so some of the intestinal disorders include the hernias, and the epidemiology for hernias is there 700,000 inguinal hernia repairs performed in the United States. But it's the protrusion of the abdominal contents throughout area of weakened muscle in the abdominal cavity, and so it makes this bulging appearance. It can occur anywhere in the body, but it mostly occurs in the abdominal cavity with intestines protruding through an abnormal opening. And it's described either reducible or irreducible. Here are some of the functions that I just talked about. So this is the pyloric canal in the body and the fundus. So the functions of the gastric juice, it's mainly responsible for digestion of protein and some lipids and carbohydrates, and then also helps with the absorption of the extrinsic factor, and then helps form the chyme. I hope you've all reviewed the assessment portion of the GI system, which is in your textbook. So these are some of the upper GI disorders, like I mentioned, the hiatal hernia, and then we have the gastroesophageal reflux, which is also referred to as GERD, esophageal cancer, and peptic ulcer. Let's go back up a little bit to the previous slide. So for hiatal hernias, we have some of the types of the hernias that are out there. So there's the inguinal hernia, femoral, umbilical, and ventral or incisional. And they're all managed differently. So hiatal hernia, some of the symptoms this patient may exhibit is sometimes there's pain or gastroesophageal reflex, because it's basically pinching off the esophagus, and so it can affect the person's ability to breathe normally because it's pressing up against the diaphragm. And the tests that are ordered for this is either CT scan, X-ray, or MRI if they want to see something more detailed. So the way to manage this is for small frequent meals, then elevate head of bed 4 to 8 inches, and sometimes if it's really severe, they do surgery. But surgical management is the most common management of the hernias, and it's called hernioplasty. But if the patient is a poor surgical risk, a binder may be applied to basically help reduce the hernia, so that reduces the complication. The surgical procedure to repair the hernia is called herniorrhaphy. Often the patient may have a synthetic or biological material called mesh placed to reinforce the area of weakness and prevent recurrence of the hernia. And so whenever the mesh is used, then we'll refer this to the procedure as hernioplasty. Another GI disorder we'll talk about is GERD. And so GERD is the risk factors for GERD is the decrease in motility, hiatal hernia, and pyloric stenosis. And it can lead to Barrett's esophagus. And the symptoms include pyrosis, dyspepsia, regurgitation, pain with swallowing, hypersalivation, and chest pain. Pyrosis is basically a fancy word for heartburn, and dyspepsia is that feeling of fullness which can be accompanied with nausea. Okay, let's talk about GERD. So gastroesophageal reflux disease, that's the meaning of GERD. As you can see, these are the pictures of some of the foods that you should avoid if you're experiencing GERD. And these are some of the things we need to teach our patients to avoid, especially if they're having really bad symptoms. So the epidemiology for GERD is results from backward flow of gastroduodenal contents into the esophagus or adjacent organs, and it produces a variety of symptoms that may or may not cause tissue damage. Reflux occurs when the lower esophageal sphincter, sometimes you'll see it referred to as LES or abbreviated as LES, is weak or relaxing inappropriately, and it causes the pressure gradient between the lower esophageal sphincter and the stomach to be lost. And GERD occurs almost in association with hiatal hernia, but herniation of gastric mucosa does not occur with GERD. There are many factors that are associated with a decrease in LES pressure that influence transient or chronic gastroesophageal reflux. And common examples is, like I mentioned before, the hiatal hernia, the LES hypotension, and then sometimes loss of esophageal motility, the increase in the gastric secretion production, so to speak, and then eating large meals, especially when it's late at night, and delayed emptying of gastric contents can also be a risk factor, and obesity. So like I mentioned, the foods that you should avoid, excuse me, avoid drinking or eating 2 hours before sleep, and then elevate head of bed 6 to 8 inches. And some of the medications that need to be avoided, NSAIDs like, say, aspirin and ibuprofen. So when the esophagus is inflamed or injured, the ability of the esophagus to clear reflex material becomes slower, and as a result, the esophagus is exposed to the material from the stomach, and for the most part, this material is acidic, and so that's when patients feel the burning sensation or inflammation. One of the ways that this is managed is a 24-hour ambulatory esophageal pH monitoring, which basically records the pH of the stomach through a catheter that is placed in the nose and terminating at the distal esophagus. And then there is also esophageal manometry or motility testing, which is the gold standard for the assessment and measurement of esophageal motor activity. So basically, catheters are filled with water inserted into the nose or mouth and withdrawn slowly while reading of the LES pressure, and the peristalsis is taken. Pharmacological interventions include the antacid. Antacids basically increase the gastric pH. And then we have the histamine receptor antagonists, which decrease the gastric acid production. And these are normally short-acting. So basically, if you need immediate relief, the H2 antagonists are your drug of choice. And then we have prokinetic medications, which increase gastric emptying. And then the most common one that we all know about is the PPI, proton pump inhibitors. They decrease the gastric acid production, and they are long-acting. So these are usually given, say, 30 minutes before patients eat. The PPIs normally, they are prescribed either every 12 hours or every 24 hours. The risk with the PPIs is C. diff, because they interfere with the gastric flora, and once you interfere with the gastric flora, then you run the risk of basically having C. diff. And then it also increases warfarin levels. So whenever patients are on Coumadin and they get prescribed the PPIs, the Coumadin levels have to be adjusted and then monitored closely, because if, say, a patient is within the therapeutic range for the warfarin and then they start taking the proton pump inhibitors, their levels could greatly increase and put them at risk for bleeding. And then we also have the carafate, which is also known as sucralfate. And the risk with this is constipation. So we have to be aware when patients are on these medications. You may have noticed that they always give the carafate to patients that have a lot of trouble with basically mostly ulcerative colitis patients. I've seen they get a lot of sucralfate, especially with meals, because of their inflamed GI tract. And then risk factors for esophageal cancer is alcohol consumption, tobacco, and then of course, if GERD is not managed or treated, then it can lead to esophageal cancer. And then symptoms with these patients may appear late, and some of the symptoms include trouble swallowing, and this is diagnosed through biopsy or EGD or CT scan. The management of esophageal cancer is chemo, radiation, and surgery. If you guys have had a chance to do your rotation through Tower 4, you may have seen that most of the patients that go there, that's the ENT, designated ENT med-surg unit, and so most of the patients have tracheostomies in place because of the radiation, or if they've undergone surgery, then they need to have a tracheostomy basically to protect their airway. So nursing priorities post-op after a tracheostomy. As you can see, the main issue will be airway protection. And now let's talk about peptic ulcer disease. So peptic ulcer disease, there are two types, peptic ulcers, duodenal and gastric. And the epidemiology is that peptic ulcer is very common in the US. Approximately 4.5 million people are affected annually. And the pathophysiology is that it occurs in the gastroduodenal mucosa, as this tissue cannot withstand digestive action of gastric acid and pepsin. So the erosions occur in the surface epithelium that do not have measurable depth. The term peptic ulcer disease is used broadly to include ulcerations and erosions in the stomach and duodenum from a variety of causes. Duodenal ulcers make up to about 80% of peptic ulcers, and they affect the proximal part of the small intestine following a chronic course and are characterized by remissions and exacerbations. And sometimes the complications can lead to surgery to manage, and the data shows that this affects 5% to 10% of patients who end up having surgery to manage the complications. The chronic gastric ulcers tend to occur in the lesser curvature of the stomach, and they're near the pylorus. The age group mostly affected by PUD is people between 25 and 64 years of age, and it's in America it's common basically equally in men and women. In a peptic ulcer resulting from H. pylori, acid is not the dominant cause of the bacterial infection, but contributes to the consequences. And then peptic ulcer disease resulting from NSAIDs has both topical and systemic origins. And as you can see, some of the locations of the ulcer is the one in the stomach, and then there's that one out there on the duodenum. Like I was mentioning before, some of the risk factors are H. pylori, dietary factors, NSAIDs, alcohol, smoking, and it manifests as a dull gnawing pain or burning in the mid-epigastrium, and patients can experience a heartburn, and if it's really severe, there is vomiting that occurs. You get to review this question and review your notes and come up with an answer for that. That will give you a chance to absorb the content of the lecture. So what's your responsibility when you have a patient with PUD? Basically, you want to assess the pain and what can be used to relieve the pain, dietary intake, and 72-hour diet diary. These are some of the things we can teach the patient and how to manage their PUD at home, or even just to have records for the doctor to help with the management of this. They also need to change their lifestyle and habits, such as cigarette and alcohol use. But sometimes patients just prefer basically to manage the symptoms with available medications instead of changing their habits. Because let's face it, the habits once formed, they're really hard to change. And then avoid the use of NSAIDs because this will increase the symptoms. And then teach the patients the signs and symptoms of anemia or bleeding, and then abdominal assessments. Whenever patient has PUD, they will have tenderness when you press on the abdomen, and they will tell you what areas are affecting them. So like we mentioned, lifestyle changes, PPIs and H2 inhibitors, And like I talked about this before, the PPIs should not be given, should be given with instructions to the patient if they're on Coumadin, that they need to monitor their Coumadin levels, basically their INR. And then the diet is similar to GAD, basically avoid fatty foods, spicy foods, alcohol, and smoking. Antibiotic therapy, if patient has H. pylori, so basically it's a combination of antibiotics and antacids, and it's given, I believe, for the course of 2 weeks, 14-day course, depending on the severity of the patient's PUD, and then also depends on what medications patient can tolerate or is allergic to. As the antibiotic therapy for H. pylori, it's usually, I believe, it also includes, I believe they're given 3 medications, 2 antibiotics, 1 to manage the GI, and I'm not exactly sure, but I know it's a combination of 3 medications, which includes also the antacid. And then if all that fails, they can undergo surgery in extreme cases. This is where I was mentioning about 5 to 10% of patients may require surgery to manage this. And now moving on. What is the best time to teach a client to take PPI? It is normally given 30 minutes before a meal. And that's why it's, for the most part, whenever a patient is hospitalized, the PPIs are given at 6 a.m., but breakfast is not served until about, depending on what unit they are on, it's so around 7:30 or even 8. So that basically gives it enough time to prevent acid whenever the patient has their meal. Some of the complications of PUD include hemorrhage, perforation, and pyloric obstruction, basically gastric outlet obstruction. So with the hemorrhage, whenever a patient comes in with a GI bleed, they undergo an EGD to locate the whatever area is bleeding. And so with the EGD, they are able to either cauterize the bleeding area, or if it's not possible to cauterize, these patients can undergo surgery, like we mentioned before, because with continued bleeding, patient will end up being anemic, and that will not be good. So these are some of the surgeries: vagotomy, Billroth 1 and Billroth 2. All procedures can cause fullness, dumping syndrome, and diarrhea post-op. I'll ask you to please review those. I'm not sure whether this is described in your textbook, but you just need to know them. What is dumping syndrome? Dumping syndrome is basically when patients eat and then they get full really fast. So, like I was saying that the patient, basically the food will go down the GI tract faster than it should. And so the patient ends up not absorbing any nutrients in the small intestine. And this can be seen when some of the symptoms will be nausea and abdominal cramping. And the dumping syndrome occurs whenever some patients have had some form of GI surgery to help reduce their weight, basically termed weight loss surgery. And one of the ways to prevent this is to advise patients to not drink fluids with their meal, and that will help alleviate the dumping syndrome. Oh, there we are. So avoid foods that cause problems. Not sure what that means. And then eat small frequent meals at least 6 times every day. So basically it gives the GI tract time to absorb the nutrients with small amounts. Don't drink fluids with your meal. Drink liquids at least a half hour to an hour after eating solid food. And then avoid simple sugars such as sweets, candy, soda, cakes, and cookies. Do not lie down as soon as, this is the opposite of God. So basically, lie down as soon as you finish eating to slow the emptying of food from the stomach. And then avoid foods that are very hot or very cold. This brings us to the end of this slideshow, and we will go through some of the things you should focus on for the exam on my next lecture. But since we're here and we just talked about dumping syndrome, basically know what foods to avoid, and then also how to avoid peptic ulcer.